Good afternoon, everyone, and welcome to today's ESNM GMFH webinar. My name is Daniel Pohl from the University Hospital of Zurich, Switzerland, and I'll be delighted to chair this very interesting session that we have today. I would also like to welcome our two speakers today. Firstly off, Stephen Johnson from Boyce Creek in the United States. He's an infectious disease specialist working in a busy GI practice and is a specialist to manage the recurrence of Clostridioides difficile infection. This talk will be followed by a presentation by our colleague Tariq Iqbal, a gastroenterologist from Birmingham in the UK, and he will enlighten us on the management of severe Clostridioides difficile infection. Now, before we get started, I'd like to go over a few items so you know how to participate in the event. I would also especially like to thank our sponsoring partner who made this webinar possible, which is Ferring Pharmaceuticals. They are supporting the whole ESNM GMFH webinar series that we are doing this year. All right, so there is a control panel. We've taken a few screenshots, see how it looks at. You should find it at the bottom of your computer desktop, or if you use your cell phone on your cell phone. You should be listening in using your computer speaker system by default. If you do have any scientific questions or any questions in the meantime, you will have the opportunity to submit text questions in the Q&A box, which you see here on the lower part of the control panel. You can send in these questions at any time to the presentation, and we will collect them and then address them during the Q&A session towards the end, the last 10-15 minutes of today's webinar. Interaction, I think, is very important, so please do not hesitate to put down your question in the Q&A. Then there's also a chat function that provides the ability to send instant messages during the session. I hope you won't be able to need that. That would be for technical difficulties. If there may be polls, I think we're not doing polls today, if I'm correct. Maybe we'll do this in the discussion section. You could obviously do that also as part of this presentation. Again, I'd like to thank Ferring Pharmaceuticals for supporting this. The next webinar I would also like to highlight. These are the whole series that you're seeing. We are on the second last talk today of prevention of recurrence and reinfections, and the next and last webinar will be on future perspective on November 22nd. Please register under our homepage, our ESNM homepage, and we would also welcome you, obviously, then. So, yeah, without further ado, I'd like to hand over the screen to Stephen Johnson. Stephen, thank you so much for giving your talk today, and please, you may take over.
All right, thank you very much. Let me just pull up my presentation here. Looks like it's not letting me, there we go. Everyone see that okay? You guys see that?
No, for the moment, only a black screen. You might have to do the change of screens again.
Okay, how about now? Can you see that?
Yes.
Okay, thank you. All right, well, thank you for that introduction. It's great to be here today, and thank you for this opportunity. Talking about prevention of recurrence is something that I'm very excited about. It's something that I've spent quite a bit of time researching over the last few years, and so excited to be here today. Hopefully there's a lot of questions later that we can discuss as well. So first, I just want to note that I have no conflicts of interest to disclose. First, just provide a little bit of background. I know you're all aware about the issue with recurrence of C. difficile infection. I just want to provide you some figures that has been published on here recently. But obviously, Clostridioides difficile infection is characterized by frequent cases of recurrences. And because of those recurrences, it is a major clinical challenge that's associated with significant morbidity and significant mortality. And because of these recurrences, there's a lot of strategies that individuals have employed to try to prevent or mitigate this risk of recurrences. And given this, there's a lot of differences as far as that strategy. And actually, some of these prevention strategies are actually controversial, and I'll talk about some of those later here in a little bit. It's very well known that recurrence typically occurs in those first 1 to 4 weeks after completion of anti-CDI therapy. Now, as far as that risk for recurrence, it really depends upon the number of episodes that an individual has. Very clearly, the data supports that for each subsequent case of CDI, your risk for recurrence increases. And if you look at some of the published literature, up to a 25% chance of recurrence after that initial CDI episode, up to a 45% chance after that second case of CDI, and up to a 65% chance after 3 or more episodes of CDI. So very clearly, our risk for recurrence increases with each subsequent case of CDI. So to provide you some more figures as far as the morbidity and mortality, very clearly, again, increased morbidity and mortality. Up to half of all patients with recurrence have a CDI-related readmission. A 33% higher risk of death with recurrent CDI compared to those who don't have recurrence, and associated with prolonged hospitalizations in those that have recurrence. So again, significant morbidity, significant mortality. And so what do we do about this? Well, one, we need to identify the risk factors for recurrence. Hopefully, if we can identify the risk factors, we can try to do some things to mitigate or prevent recurrence of CDI. Unfortunately, I will note that many of the risk factors that have been published on are non-modifiable or unavoidable. Very clearly that advanced age is associated with the increased risk of recurrence. Immunosuppressed, whether that's immunosuppressing disease or being on immunosuppressive therapy, recent or prolonged hospitalizations, GI procedures, and then antibiotic exposure after that index CDI episode. So again, a lot of these risk factors are non-modifiable or unavoidable. We can do our best with various antimicrobial stewardship efforts to try to reduce unnecessary antibiotic use, but antibiotics are unfortunately needed for many infectious diseases, and so we can do our best to avoid antibiotics. But again, a lot of these risk factors are unavoidable. So what can we do? Very clearly, the data supports that we can think about our initial therapeutic options. The choice of that initial therapeutic option can be associated with less recurrence and may be a better option for treating that initial case of CDI to prevent recurrence down the road. So we can look at initial therapeutic options with utilizing things like fidaxomicin versus PO vancomycin, looking at multiple recurrences, obviously utilizing things like FMT or bezotuximab plus standard of care. These are things that we can employ or try to utilize to prevent recurrence down the road. So I'm sure you're probably aware of some of the data that's out there that looks at these different therapeutic options and the risk for recurrence. This was a table published in the IDSA 2018 guidelines that directly compares fidaxomicin versus oral vancomycin. And if you look at the primary endpoint with resolution of diarrhea at the end of treatment, so our primary efficacy endpoint, very clearly that both of these are effective options in the high 80 percentile for resolution of diarrhea after 10 days of treatment. But if you look closely at recurrence, this is where fidaxomicin becomes a much more attractive option. And so this is looking at resolution of diarrhea at the end of therapy, and then also those that continue to that do not have diarrhea after 1 month of treatment, so continued or sustained response. Fidaxomicin group was 71% versus oral vancomycin 57%. And that had a relative effect of 1.2, a confidence interval of 1.1 to 1.4, and a statistically significant p-value. It's very clearly that fidaxomicin had less recurrence compared to oral vancomycin. You can also look at several other studies that are published out there that show this same finding. This was a prospective, multi-center, double-blind study that compared one treatment arm that received fidaxomicin for 10 days versus oral vancomycin for 10 days. And again, if you look at the clinical cure rate, relatively similar here in the upper 80 percentile for clinical cure. But again, what's very compelling here is looking at the recurrence rate. So recurrence with fidaxomicin was 15.4% versus oral vancomycin of 25.3%, which was statistically significant. And again, there's other studies that are out there as well that show the same finding. This was another multi-center, double-blind, randomized non-inferiority study that had two treatment arms of fidaxomicin and oral vancomycin, showing similar percentages as far as clinical cure in the upper 80 percentile, and then showing similar percentages with recurrence. Fidaxomicin at 12.7%, oral vancomycin 26.9%, and again, clinically or statistically significant again. So very clearly, fidaxomicin is associated with less recurrence compared to oral vancomycin. What about FMT? There's also data looking at FMT compared to standard of care with oral vancomycin. This table was also published in the IDSA 2018 guidelines that directly compares FMT and oral vancomycin. This endpoint took it out a little bit further. And so instead of looking at 1 month post-treatment, this looked at 56 days after treatment and looking for resolution of diarrhea 56 days after completing anti-CDI treatment. Those that received FMT had a resolution of 81% versus those with oral vancomycin much lower at 31%. And this had a relative effect of 2.6 with a confidence interval of 1.1 to 6.2 and a p-value of 0.01, so also statistically significant. So very clearly FMT associated with less recurrence compared to oral vancomycin. And if we look at another study that was published in 2013, this was looking at individuals that had recurrent C. difficile infection, had 3 different treatment arms, those that received high dose oral vancomycin plus a bowel lavage plus FMT, or those that received high dose oral vancomycin plus a bowel lavage, or just oral vancomycin by itself. And essentially what this study found is those that received FMT in addition to the oral vancomycin and bowel lavage had more or better effect than those treated with oral vancomycin by itself. So again, very clearly that FMT is a more effective treatment option and also associated with less recurrence. So what about our newest agent? Now I know this isn't available everywhere yet. This is newly available here in the United States with bezlotoxumab. This table here summarizes the big take home here with bezlotoxumab. So it looked at bezlotoxumab plus standard of care or standard of care by itself, and looking specifically at recurrence rates. The gray bars there show recurrence rates in those that receive standard of care. The maroon colored bars there show recurrence rates in those that receive bezlotoxumab plus standard of care. And as you can see here very clearly, the recurrence rates were higher in those that received standard of care by itself compared to those that received standard of care plus bezlotoxumab. And they looked at this at 12 weeks post completion of CDI treatment. And again, both of these showing statistical significant differences between the 2 treatment arms. And if you think about this clinically and applying this into practice, if we look at actually utilizing bezlotoxumab plus standard of care in practice, if you calculate a number needed to treat, whether you use the Modify 1 data or Modify 2 data, the 2 main studies evaluating bezlotoxumab, both of these studies showing if we treated about 10 individuals, we can prevent 1 episode of recurrent CDI. And so the question to ask yourself is, well, should we utilize this sooner on in the treatment of CDI to prevent recurrence, and is that cost effective to do so? And so that leads us to this slide here as far as what do we do with this information? Obviously, very clearly, fidaxomicin associated with less recurrence. just as effective as oral vancomycin. FMT, standard of care plus bezotoximab, associated with less recurrence. So what do we do with this data? Based upon this data emerging, a lot of the clinical practice guidelines have changed over the last few years, where now fidaxomicin has become a more recommended initial therapeutic option, and that's given the lower incidence of recurrence compared to oral vancomycin. And then also, one of the things that we were hesitant to do at our practice site is, before we started implementing fidaxomicin for initial therapy, we weren't sure if it was a cost-effective option. It's significantly more expensive compared to oral vancomycin, but there is now data to support that fidaxomicin is a cost-effective option as well. And so kind of a rhetorical question I'll ask, maybe we can discuss this later, is I'm curious how many are utilizing fidaxomicin now for initial CDI, given these changes in the practice recommendations, given now that we have some of this cost-effective analysis data coming out, and now given that we're getting more used to using fidaxomicin as initial therapy, are you all actually utilizing this for initial cases of CDI? And again, maybe we can come back later and discuss that. I'm curious if there's any comments around that. Next, looking specifically about standard of care and bezotoximab or FMT. If you look in the guidelines, typically these are only recommended in recurrent cases. Now, I will say though, standard of care plus bezotoximab is actually recommended in initial CDI in those that have high risk for recurrence in the European Society of Clinical Microbiology and Infectious Disease guidelines. That was a recent change for them, and is now an initial therapeutic option. And also there's some data that supports these as cost-effective options as well. So again, another question to think about, or maybe we can touch on later, is based upon this data, are you utilizing these for initial CDI? I'm not aware of any institutions that do FMTs for the first initial cases. I'm not aware of any institutions that are doing standard of care plus bezotoximab for initial cases of CDI, but I'm curious, at your various institutions and practices, is this something that you all are considering or doing? So obviously, our initial therapeutic options are ways that we can prevent recurrence, but there's a lot of standard, well-documented CDI prevention strategies that everywhere is utilizing. Unfortunately, a lot of these standard prevention strategies focus more on primary prevention and not necessarily recurrence, but also can prevent reinfections as well. So our classic infection prevention strategies, isolation, disinfection, hand hygiene, and obviously stewardship is associated with reduction in CDI cases. But what can we do about recurrence? Obviously, again, we could try to avoid antibiotics and do the best that we can with stewardship. But as I've alluded to already, antibiotics are not completely unavoidable. That we can do the best that we can there, but we need to treat certain infections with certain antimicrobials. So what are our other options for prevention of recurrence? So I listed some other strategies that have been employed and strategies that have data out there. One being the utilizing probiotics. It makes sense that CDI rises due to disruption of gut flora. Perhaps we can provide probiotics to restore the gut flora and prevent CDI recurrence. And specifically, probiotics are mainly utilized during systemic antimicrobial use. I would note that probiotics are not recommended, and that's in multiple practice guidelines, and that's given that there is data that shows that there may not be a benefit. There are some data that show that there may be a benefit, but there's not enough consistent data that says that probiotics work. And given that, a lot of practice guidelines do not recommend that they be used routinely. There's also perhaps the discontinuation of PPIs as a way to prevent C. difficile infection. I will also note, if you look at the various guidelines out there, most of the guidelines will say that really we should just be reviewing for appropriate use of PPIs, which we should be doing in context of CDI or not, that we should be reviewing for appropriate use. Obviously, if PPIs are not being appropriately used or there's not appropriate indication, they should be stopped. But the IDSA guidelines take it a step further that say, really, there's insufficient evidence for stopping PPIs as a measure to prevent CDI. So if they're being appropriately used, go ahead and continue that appropriate PPI. The last one gets to the more controversial method to providing prophylaxis, and that's using anti-CDI options. And again, I will note that this is controversial. This is what I've been working on over the last few years with looking specifically at oral vancomycin. And I will note that this is now recommended in some of the practice guidelines. There are some data, though, looking at metronidazole and fidaxomicin as well, too. But mainly what I'm looking at is utilizing oral vancomycin as a prophylactic measure. Again, I just want to note that this is a controversial practice to employ. With looking at metronidazole, I will caution you that this is not a good prophylactic option, that the data does not support the use of metronidazole as a prophylactic option. And then also the risks probably outweigh any potential benefit that you may gain for metronidazole. So this has kind of fallen out of favor. I don't know of anyone using metronidazole prophylactically. Next, that takes us to oral vancomycin. Oral vancomycin has the most data available for utilizing it as a prophylactic option. Last I looked just a few weeks ago, to date, there are 12 published studies looking at the utility of oral vancomycin prophylaxis. I will caution, if you look at that data, though, there's a lot of differences in the data that is available. Differences in the patient population that was evaluated, differences as far as whether it was utilized as primary or secondary prophylaxis, differences in the dose. A lot of different doses utilized, doses as low as 125 milligrams daily, doses as high as typical treatment doses. And there's a lot of variability in the duration that it was utilized as well. Regardless, though, of those differences, if you look at the data in sum, most of the data shows that there probably is a benefit with providing oral vancomycin prophylaxis and perhaps a minimal or no major safety concerns with its use. Now, I will caution, though, before you think about employing or utilizing oral vancomycin prophylaxis, there are a lot of unanswered questions. This is the primary reason why we don't do this routinely at my institution, is there's still some questions that we're trying to answer. One of the big unanswered questions is well, what is the optimal dose? The dose that we researched was 125 milligrams daily. And that's also recommended in ACG guidelines of doing 125 daily. Also, there's recommended doses of doing 125 milligrams twice a day. But again, there's a lot of different doses that were utilized in the research. And the issue with the dose is you don't want to provide too low a dose. And at the flip side of it, you don't want to provide too high of a dose. Providing too low of a dose, the concern there is for causing selective pressure for more resistant strains of C. difficile infection. Then also providing too high of a dose, you're going to cause more gut disruption and may increase the risk for recurrence down the road. And so that optimal dose isn't known quite yet. And then also, how long should the prophylaxis be given if it's given? What we researched was we gave it during the use of systemic antimicrobials and continued it for 5 days after that antimicrobial was stopped. But the most appropriate duration is not known as well. And then our biggest question that we have, and the main reason why we are not utilizing this on a regular basis, is who should be targeted? We know some of the risk factors that are out there, but ideally we would like an institution-specific risk prediction model. And the reason why it needs to be institution specific is there's a lot of variabilities in the risk factors that have been identified. And to date, no universal model has been created yet that is highly predictive. And so ideally, this would be an institution specific model that has very, very high probability of predicting those that may acquire C. diff or recurrent C. diff, and those should be the individuals who should be targeted. And again, to date, a model like that has not been created. And then lastly, there's still some safety concerns there. We know oral vancomycin does disrupt the gut flora. What are the long-term consequences of that? The increased risk of colonization of resistant organisms like VRE. And so there still are some safety concerns before we should really, again, utilize this on a regular basis. And that brings us next to fidaxomicin. Fidaxomicin is clearly probably the better option to utilize in a prophylactic manner, given it has less disruption of the gut flora. The problem with fidaxomicin, though, is there's very limited data. The data that is available did show that it decreased the rates of CDI, but we have the same unanswered questions. How long should it be provided? Who should we target with it? And then also, I would argue that it's probably a cost prohibitive option. Given how expensive it is, it'd be very hard to justify this as a use of a prophylactic option. you would have to have a very, very predictive model in order to roll this out prophylactically, which again has not been created to date. So that leads me to some potential future options. This is something I'm very excited about, something that there's a lot of literature coming out as far as utilizing live microbiota biotherapeutics for preventative strategies. And really, this is based upon the underlying science from what we've learned with FMTs, that we're trying to recolonize the gut flora with that good bacteria. I would argue that perhaps this may be a more regulated, which would perhaps provide a greater safety net product compared to FMT, possibly a reduced risk of transmitting infectious agents with these regulated products. I will note that there's 3 products that are likely to receive FDA approval here in the United States, but also available in other countries probably in the near future. The 3 to keep a lookout for that are furthest along is RBX 2660. That's given rectally times 1 dose. There's also SIR 109, which is an oral agent, which is given 4 capsules daily for 3 days. And then CP 101, which is given orally times 1 day. And these are all given after an individual has completed treatment for their CDI. I will note that all of these have clinical data showing a statistically significant reduction in recurrence of CDI. And if you're curious about the specific endpoints and what they found in those studies, I listed those here where you can pull those up. RBX 2660, you can look at the Punch CD studies. SIR 109 is the EcoSpore, and then CIP 101 is the PRISM 3 studies where you can pull up and look at the data that they found with these specific agents. I will say that there's some unanswered questions with these live microbiota biotherapeutics that I'm still waiting for answers. One will be well, when are these agents available? In the United States, we may have one of these available by the end of the year, possibly beginning of next year. And then these other ones probably mid or later next year. But the biggest question I have about these agents is how much will they cost? Are they going to be a cost-effective option or not? Are they going to be cheaper than FMT? And if they are cheaper than FMT, one of my ultimate questions is, well, will these replace FMTs in the future? And so that's yet to be seen. I think it's going to take some clinical practice with utilizing these agents and experience with them. But will these agents replace FMTs in the future? That, again, is yet to be seen. And I think we have enough time here. I'll just cover this here very briefly as far as my practice sites. My practice site's at Novant Health. It is a 4-state network of 18 different medical centers. The flagship medical center is at Forsyth Medical Center, which is in Winston-Salem, North Carolina, here in the United States. It's just under a 1,000-bed hospital, has all the services that you expect of a tertiary medical center. And as far as what we are doing right now to prevent recurrence of CDI, the big thing is our robust stewardship program. So we have several antimicrobial stewardship pharmacists and other individuals that are on that team, really trying to focus on avoiding specific antimicrobials to try to reduce C. diff. And also, it's up to the provider right now whether or not they're going to utilize oral vancomycin prophylaxis. We have not rolled out a standard as far as who should receive that. Again, still waiting on some more data there. And then lastly, we're starting to utilize fidaxomicin more frequently for initial episodes of CDI. And so that's currently where we're at right now until more data comes out, until perhaps maybe some of these live microbiota options may be available in the near future as well. And so I'll stick around for any questions at the end, and I'll now turn over my time. Thank you.
Thank you very much, Stephen. We'll discuss in the beginning. We have one question currently in the question and answer box, and please do ask more questions. We collect these and then discuss them later towards the end of this webinar. I would now like to ask my colleague Tariq Iqbal from Birmingham to please continue and to give us his talk. Really looking forward. Thank you, Tariq.
Yeah, thank you very much, Dan. Can you allow me to share the screen, please? I think I need to be given that permission. So
yes,
can you,
Stephen, you need to do that.
Yeah, Stephen, you need to. There you go. No, still can't do it.
On the upper right.
I think possibly the host has to do this for me.
Well, I can try it again.
Yeah. I think Stephen's still sharing as well.
Yeah, he's still sharing, I think.
Yeah.
All right, it should be off sharing now.
There we go. Okay, that's it. Thank you.
Good.
Okay, so thank you very much for inviting me to give this this talk about the management of severe CDI. Yeah, it's all antibiotics really. This is my disclosure slide. Yeah. There have been a couple of, and my talk is going to be based on a couple of recent guidelines which have been published within the last year, both from the UK and from the US. And then just really an update on information around FMT, which I think is becoming quite exciting in this space, really. So from the NICE guideline published in the UK last year, first of all, what is the definition of severe CDI? Well, the definition, according to NICE, was if you have a patient who's got a white cell count of more than 15 by 10 to the 9 per liter, if there's an increase in serum creatinine by more than 50% from baseline, if the patient is pyrexial over 38.5 degrees, and there's severe radiological evidence of severe colitis. And a low albumin also plays into this. And although this is the low albumin comment is not made in the NICE guideline from the UK, but it comes from the American College of Gastroenterology, who recognize that low albumin as an indicator of both an acute phase response and also a leaky gut is an indication of severe CDI. Oh, what's going on? Okay, so this is a CT which gastroenterologists will typically recognize as showing severe thickening of the colonic wall with some fat stranding in this dirty mesentery and the dilated bowel, severe colitis. This is an indication of severe CDI. Life-threatening CDI as defined by the NICE UK guidance is in those patients who have those features, but also hypertension, ileus, a toxic colon, and also CT evidence of severe colitis as well. So these patients really you can't hang about. And the question is, and has been discussed in many guidelines for the last 10 years, is what's the best antibiotic to use? And antibiotics are clearly first line still in the management of fulminant CDI. So from the UK NICE guideline, we have an equal recommendation both for vancomycin, 125 milligrams orally 4 times a day for 10 days. The higher dose is really not showing any better effect in the studies, and then a second line indication for fidaxomicin to treat for 200 milligrams twice a day for 10 days. And one has to take this with a little bit of a pinch of salt, because of course the UK NICE guidance is very much a cost effectiveness guidance. And I think given the NICE data that Stephen has just presented on recurrence rates after fidaxomicin, then one has to consider whether in severe CDI, we're happy to wait 10 days for vancomycin to perhaps fail, and then to use fidaxomicin. So I think these are guidelines after all, and I think these antibiotics should be considered in an individual patient case with a careful consideration as to which one you want to use first. If the antibiotics for the first and second line antibiotics are ineffective, then in the opinion of NICE from the UK, then we should be using a bigger dose, 500 milligrams 4 times a day of vancomycin. And they do suggest that specialists will sometimes add in 500 milligrams 3 times a day of metronidazole in this situation of severe CDI. In the life-threatening patients with severe CDI, then again, the UK NICE guidance suggests seeking urgent specialist advice, including surgeons, and using again a high dose antibiotics, as suggested before, with vancomycin and metronidazole combined, with the context of using vancomycin enemas if there is an ileus as well. The American guidelines published almost the same time last year, again agree that severe CDI is classified in patients who have a white cell count of more than 15 and a serum creatinine, elevated serum creatinine. They also point out that high fecal calprotectin has been shown in studies to be a marker of severe CDI, and also peripheral eosinophilia is a good marker. It's either very elevated or undetectable as a sort of as it's washed out of the bone marrow. And the presence of pseudomembranes at endoscopy is also very useful. And certainly this becomes important when I talk about the use of FMT in the management of severe CDI. The American guidelines make vancomycin and fidaxomicin equivalent, really, in terms of you can choose, and there's no recommendation of using metronidazole at all. So again, vancomycin or fidaxomicin are first line for 10 days as initial treatment for patients with severe CDI. For fulminant infection, from the American guidelines, they again agree that hypertension, ileus, or megacolon is a criteria, but they actually are very much more come with a strong recommendation for early involvement of a multidisciplinary team in the care of these patients. And I think that's really important. It's not good enough to just call your surgeon on a Friday afternoon when the antibiotics are failing. It's important that the multidisciplinary team, including a gastroenterologist, infectious diseases person, and a surgeon as minimum, but perhaps with a microbiologist, should be involved in the management of these patients early, I think, as this prevents last-minute disasters, really. Garen, the American guidelines agree that apart from volume resuscitation and supportive care, high-dose vancomycin should be used in patients with life-threatening fulminant colitis, with parenteral metronidazole, again in these patients with fulminant disease, as a consideration. And for those patients who require surgery, it's recommended that timing given the patient's disease should be a total colectomy with an end ileostomy, or if the patient is not fit enough to have a total colectomy, then a diverting loop ileostomy with colonic lavage and intraluminal vancomycin, depending on how fit the patient is. But if the patient can to the UK, the American guidelines, which are not based on cost effectiveness but on clinical consensus more, do suggest that FMT should be considered for patients with severe and fulminant CDI, which is refractory to antibiotic therapy, particularly when these patients are deemed poor surgical candidates. And I think this is the important trial which has really highlighted the importance of FMT in treating patients with severe colitis. Before this, Monica Fisher in the States and Tom Barodi in Australia had reported on case series, a retrospective case series, and shown that FMT was apparently safe in the management of patients with severe CDI. But this was an open-labeled, randomized controlled trial comparing FMT combined with 14 days of vancomycin compared to as a single infusion versus multiple infusions in patients with severe CDI. So these patients all got FMT plus antibiotics, and they either had a single infusion or multiple infusions. And the multiple infusions were driven by the appearance of the colon in terms of the resolution of pseudomembranes. And they managed to cure 75% of individuals with a single FMT, and all 7 who failed after the single FMT were then resolved after repeated FMTs. And of those patients who had had the repeated fecal transplants, there was 100% cure rate, and 57% of those were fulminant or life-threatening. And there were no serious adverse events in this trial. So I think that's quite good trial data recommending FMT for these patients with severe CDI. And since the centers have started doing FMT, then they have actually seen, so from this paper from Rome, looking at the cases of CDI from 2009 onwards, from the initiation of FMT in 2013, Dr. Camerota was able to show that colectomy rates fell actually to 0 at the time this paper was published in 2015, 2 years after the introduction of FMT. And from the North American group, from Jessica Allegretti and Monica Fisher, they're able to show a reduction in mortality related to the introduction of the FMT program from 43 to 12% for refractory fulminant CDI. So this, I think, is important data. This is just a picture of how you do FMT. This is for gastroenterologists on the call. This is a colon, and in the bottom left here, you can see a catheter, a blue catheter, and there's an introduction, and the top right there of the fecal material into the colon. On the bottom right, you can see a pool of FMT in the colon. And this is not something to be undertaken lightly or by inexpert colonoscopists. We've done a trial recently in IBD, and I can tell you that the technique of doing colonoscopy and putting FMT into the colon is very different from a standard colonoscopy. You've got to be very careful about the amount of air you put in and the amount of air you suck out, as is dangerous. So there's the danger of sucking all the FMT out as well. This is a picture of a patient with severe pseudomembranous colitis, and you can see the bowel is quite hairy and inflamed here. FMT needs to be done carefully and trying not to do a full colonoscopy, but getting the FMT at least into the transverse colon, but it is effective. Just looking at some older guidelines. So these are the American infectious disease guidelines from 2018, the European guidelines from 2013, and world guidelines from 2019. And you can see here that more recently, fidaxomicin in this last column has come to be considered as similarly efficacious for the treatment of severe CDI as vancomycin, as Stephen was alluding to, really, whereas the older guidelines suggested that it should be second line in the treatment of CDI. So I think fidaxomicin gets a thumbs up as a first line treatment here. This is an old Korean guideline from 2010. You can see that FMT was somewhat optimistically recommended for refractory CDI by the Koreans in 2010 before the data came out from Rome, and I think this is a very foresighted of the Koreans. FMT is not necessarily without risk. There have been some cases in America which the FDA brought to light just before the pandemic of patients who received multi-resistant E. coli, and one of these died. This is a result of inadequate screening for samples in the stool. But this systematic review of more than 4,000 patients who received FMT in clinical trials published in 2021 indicates that although the side effects are common, particularly diarrhea, abdominal discomfort, nausea, flatulence, constipation, these are short-lived and mild. there were a very small number of patients in all out of these 4,000 who had serious adverse events. And these were like about 50 patients out of 4,000. And this is in patients with a mucosal injury, so patients with colitis and both for C. diff and inflammatory bowel disease. Number of deaths was very low, and this was related to aspiration in a couple of cases. So that's, I think, indicates that there is a place for FMT in the management of CDI, as well as antibiotics and careful supportive management of these patients. I just wanted to highlight this really quite important trial. It's slightly off target topic, but going back to what Stephen was saying about using FMT earlier, this has just come online in Lancet this September. And I think it's a very important study from Denmark, in which patients with either first or second episode CDI were treated with FMT or placebo. So this is 60% of these patients, of these 42 patients, had the first episode of CDI. They all got 10 days of vancomycin, and then they were randomized to either receiving 2 doses of capsulized FMT over a period of a couple of weeks, or matched placebo, with the primary outcome being resolution of Clostridioides associated diarrhea at week 8, which is what we all use really, a clinical indicator of efficacy. And the trial had to be stopped early because of a dramatically different response in the FMT compared to the placebo arm. So at week 8, 90% of patients who got FMT versus 33% of placebo patients had a resolution of diarrhea. And of those patients who had their first episode, it was actually a little better, even 93 compared to 36%. Of course, there's not long-term follow-up here, but I think this is an important trial. The patients had a 57% response to vancomycin before randomization to FMT or placebo, and that was the same in either group. So I think this is quite an important study, because actually, let's not get to recurrent, refractory and severe C. diff if we can switch it off earlier. And I'm hoping that this is going to switch on more work in the future in this space. An important message from this paper, also from a European study which we were involved with last year, was that at present only 10% of patients in Europe with multiple recurrent C. diff infection and indication for FMT actually receive it. In the UK, recently, NICE have just a couple of weeks ago recommended fecal transplants for recurrent C. diff infections as being cost effective compared to vancomycin or fidaxomicin. They didn't consider C. diff, severe C. diff, because there isn't enough data there to make a cost effectiveness assessment, which is what they're all about. So yeah, I just wanted to kind of give an advert for anybody in the UK. We have a licensed stool back in Birmingham, and we provide about 20 or 30 FMTs for patients in hospitals around on a monthly basis. So if anybody wants to access in the UK, that's possible. So I think for severe C. diff, it's very important to have early multidisciplinary assessment and input. I think you can take a pick between vancomycin and fidaxomicin, add in intravenous metronidazole for severe cases, and high dose vancomycin for fulminant cases, with rectal vancomycin for ileus. I think we should consider FMT early in combination with antibiotics, given the data and the American guidance, which is quite clear on this. And typically for FMT studies, patients are given 3 days of vancomycin, FMT, perhaps repeated until pseudomembranes disappear, and at least 5 days of vancomycin to follow this. The Rome group who've led this really with Gianluca Iannaro leading the field, also then do an outpatient FMT at the end of it. A little advert for our ordering process. And that's all I was going to say. Thank you very much.
Thank you very much, Derek. Stephen, also please come back to us, and we would like to discuss now the two talks. And if I may start with the questions that were placed by the audience. One, a very practical one by Christina, and she was asking, how do you treat a CDI in a patient who has an ileostoma, so the colon is excluded? She's not saying if it's a double looped one or a single loop one. Colonoscopy was performed in this patient to check before re-establishing the continuity of the digestive tract. There were pseudomembranes found. They did the fecal test for the toxin, I suppose, and patient previously had surgery for diverticulitis. So obviously this is an excess situation, right? How do you deal with that? Lavages, or what do you do, Tariq?
Can I miss? Was that a loop ileostomy or an end ileostomy?
Yeah, she's not saying that. Maybe we can discuss both cases. Let's say it's a loop, so you could have an access from above. So what would you take?
I think the vancomycin is directly into the colon is used, and we've also done published a couple of cases of putting FMT approximately into the colon, which has worked quite nicely as well in that situation. If it's an end ileostomy, then I think you have either of those options. But vancomycin instilled into the defunctioned colon is something that's recommended and used in this situation.
Yeah. And even in a single loop, you would not even think about doing anything IV or systematic, right? You would try to keep it local, but then obviously you would have to be more difficult going from the bottom than rather take an antegrade lavage of the colon.
The IV stuff doesn't get to the spot, unfortunately. Yeah.
All right. Stephen, I may ask something for you. You were talking about the early recurrence or the recurrence rate, and that each time you have a recurrence, that's also a negative predictive factor for another recurrence of C. diff. Now, what do you say about timing of early versus late recurrence? Do you see any differences there? And do you do any differences in your diagnostic, also your therapeutic approach in a patient, let's say, who has a recurrence early on after 2 weeks versus a patient that comes back to you after 2 or 3 months and has symptoms that are suggestive of a recurrence?
I wouldn't say that we do anything different as far as our approach with the management. Definitely, we're starting to think about prophylactic options more, and hopefully early prophylactic options right after that initial CDI treatment. But I wouldn't say that we change our approach as far as early versus late recurrence.
Mm-hmm. You were also mentioning that probiotics, that there currently isn't a role, and Kasim is asking a question, and that may be also something that could at some point be, a protective factor, but apparently we don't know not much about that. So Kasim was asking, is it that the probiotics are currently not advised because the data that are there show a lack of efficacy, or is it because the really definitive research hasn't been performed yet, and we simply don't know because the design wasn't good or too heterogeneous studies? What's your take on that?
Yeah, so multiple reasons. One being that I would say there's a lack of evidence, and then the evidence that is available is not very high quality evidence. And so it's a combination of a lack of robust evidence and a lack of high quality evidence. And then also there still are some safety concerns with providing probiotics as well. It was thought that you're given this benign product, there's no consequence to that, but there actually are case reports of bloodstream infections with providing probiotics to certain patient populations. So if they're utilized, definitely not utilized in everybody. And so the consensus is probably not worth doing until we have better data that would support that approach.
Tariq, you agree, or do you ever use it on patients that are maybe interested in them?
No, I completely agree. I think the only sort of they've been pretty unsuccessful, really. We only use them for patients with pouchitis occasionally, but that's all. But I agree. I don't think they're benign at all. I think there are problems with these probiotics in terms of some of these things. Can I ask Stephen a question, actually?
Please.
Yeah. So I think one of the problems with most of these live biotherapies, you do have to go pretty heavy duty on the broad spectrum antibiotics with them still, don't you? Is that still
so these are after treatment of the case of CDI. So yeah, the the agents are used a little bit differently as far as whether you need to give something to clean the bowel out afterwards with, say, mag citrate, things like that. But yeah, this is after completion of CDI treatment, and then you give these live microbiota biotherapy.
I think for the rebiotics product, because it is FMT basically, there's not such a problem. But I mean, the series product, certainly you have to, without the antibiotics, they won't engraft at all, will they? That's a significant issue, isn't it?
Right. Yeah, you need to treat. Yeah, you need to treat the initial case first with something like oral vancomycin or fidaxomicin, and then you're trying to restore the gut flora with one of these products.
Derek, you were just mentioning engraftment and the need for starting an antibiotic treatment before also FMT and then also a post-treatment antibiotic, at least in some of the protocols apparently. So what do you do when there's patients that say, I'm not taking antibiotics anymore. They are the ones that got me to this problem. I want an FMT and I don't want any antibiotics around them. And maybe either of you can answer to that. Do you do that? What's the data behind it? What's your opinion?
Well, I think really that they can be persuaded to have antibiotics with 2 or 3 days. I've not come across anybody yet in whom we offer an FMT who won't take 3 days of vancomycin. That's, usually that's not in clinical practice usually a problem. And it is a pity that patients develop that attitude, because there's good data that antibiotics following FMT are more effective as well. So, and particularly if you're doing it for the severe cases, I think it's good to combine. So persuasion is the name of the game, I think.
Stephen, would you say the same, or have you come across patients that just received FMT without previous or both previous and post antibiotic treatment?
So yes, that comes up here and there. We definitely try to treat the case first with typically before FMT, we're using, I would say, fidaxomicin more commonly, or we do a less commonly a fidaxomicin chaser, ideally causing less disruption to the gut flora. But typically, yeah, we would try to convince them to use fidaxomicin first before that FMT.
So looking at the guidelines on the terms of use of vanco versus fidaxomicin as a first-line treatment, I mean, Tariq and Stephen, you both presented the individual countries' specification and how that is done. And I think, Tariq, you mentioned that I think obviously the cost effectiveness plays a huge role, especially in the British guidelines. I think that's true for every British guideline out there, at least the ones that I know. So what's your take on that? Is this going to change at some point? I mean, obviously there are huge cost differences, and maybe both of you can comment in your individual practices. What is the cost difference, number one, treating vanco PO versus fidaxomicin? And number two, do you think that also in Europe or specifically the UK will go towards more fidaxo versus vanco as primary treatment?
Sure. So I give you I guess the figures as far as how much those agents cost at our institution. So oral flagyl is about $3, oral vancomycin is $30, fidaxomicin is $3,000. Is kind of rough numbers for a treatment course. So $330, $3,000. So regardless of the guidelines now stating that this is an option for initial therapy, our big hesitation initially was, could we justify that cost difference of $30 versus $3,000 in these initial cases of CDI? I would say initially when that was reflected in the guidelines, we did not adopt that right away. We are slowly starting to utilize fidaxomicin more early on. And more frequently. And part of that's because of some of this data coming out showing that it actually is more cost effective to do it that way, that if we can prevent a hospitalization due to recurrence, that would more than justify the $3,000. And so we're getting a little more comfortable with that. I wouldn't say that we're doing it routinely with all of our patients, but starting to become a little bit more common.
Tariq?
Well, I think for first or second episode, the first episode, I think we still go with vancomycin because of the cost differential. I mean, it is, as you say, it's about 10 times as much to use fidaxomicin, and the resolution rates are not enough to kind of to make that switch. Second line, we would use fidaxomicin. With these patients, the more times use of vancomycin, the less effective it is. So from a sort of clinical efficacy point of view, we would go with fidax, but pretty much first line vancomycin because of the initial hit that we get. We don't use metronidazole at all now, oral metronidazole, because the resistance is so great and it just doesn't work.
Okay, one last question. This is from the chat. What dose of vanco is used in the enemas, and are these specifically made by the hospital pharmacy, or is this something that you buy as it is?
Yeah, I think they're 500 milligrams, actually, the enemas, and you can do 4 times a day. And we seem to be able to get them from the hospital pharmacy. Actually, one of my surgical colleagues actually prescribed it, and he didn't have a problem getting it. So,
okay,
available, yeah.
All right, good. Okay, well then I thank both of you for your excellent presentations, and I'd like to thank again Ferring for sponsoring this webinar series. I think C.diff, there's a lot of changes going around, and we have these exciting number one treatment options both on the medical side but also FMT, although we've learned that only 10% of the people who currently could actually qualify for such an option are getting it. And this is something maybe to discuss elsewhere, why that is the case and what are the limitations. But thanks for both of you. And yes, please also join our next webinar in November, as I advertised earlier. So thanks again, Tarek, Stephen, and Ferring Pharma. And you all have a wonderful late afternoon and evening.